Hello and welcome to this medical educational program. If it's the first time you're joining us, you're especially welcome. Medical exists to make medical education radically accessible to every colleague everywhere, always free and always open access. We hope you find today's CME session really useful for your own practice. I'm Matt Galsky. I'm a medical oncologist at the Icahn School of Medicine and the deputy director at the Mount Sinai Tisch Cancer Center. And I'm joined today by Dr. John Sfakianos, who is a urologic oncologist at the Icahn School of Medicine at Mount Sinai and a close colleague. Here are our disclosures. And here are our learning objectives today. So let's jump right in. Today, I'm going to talk about the role of ctDNA in urothelial cancer. Here are my disclosures. And our learning objectives today are to critically appraise clinical trial designs involving the use of circulating tumor DNA to inform treatment decisions in patients with urothelial cancer. So let's start with what we know, what we don't know, and what we might want to learn in ongoing studies. What we know right now is that ctDNA really does tell us who needs adjuvant treatment after radical surgery for muscle-invasive urothelial cancer. What we don't know for certain, although there are certainly some compelling evidence, is whether or not ctDNA tells us who doesn't need adjuvant treatment. I would say that right now, what we really don't know is whether or not ctDNA can inform us who needs neoadjuvant therapy or not. There is some early data, but we need more data to define that particular treatment decision. So I'm going to go through the data that informs each of those points, and then we'll circle back to those at the end. So ctDNA as a measure of minimal residual disease, certainly not a new field. ctDNA, in fact, circulating free DNA was first recognized in 1948, and the technology has evolved over time to be able to determine that ctDNA can represent a measure in individual patients of molecular residual disease and might serve as a key therapeutic decision point for individuals who've undergone radical surgery for a solid tumor in determining whether or not there's residual disease and informing the use of adjuvant therapy. The technology that I'm going to be discussing mostly today is tumor-informed ctDNA testing, and specifically tumor-informed ctDNA testing using the Signatera assay. And the reason that I'm focusing on this assay is that this is where the bulk of evidence has been generated to date in urothelial cancer. So this assay involves whole exome sequencing of a patient's primary tumor, identifying up to 16 alterations using that DNA sequencing data, and then designing a bespoke PCR-based assay to identify those 16 alterations in plasma samples to try and detect minimal amounts of ctDNA that's informed by a patient's primary tumor specimen. And you can see in the schema that this can be done at baseline, this can be done prior to surgery, it can be done immediately after surgery, it can be done serially, and those different endpoints probably inform different treatment decisions and have different prognostic implications as well. So let's move to this polling question. Your patient with muscle-invasive bladder cancer has undergone radical cystectomy. They ask whether their ctDNA results should determine whether they should receive adjuvant immunotherapy. You recall the results of the adjuvant PD-1, PD-L1 trials that included retrospective ctDNA analyses. And based on these data, how would you advise the patient? Would you use ctDNA as a validated tool to decide if they should receive adjuvant immunotherapy? Would you explain that ctDNA analyses in relevant trials were retrospective and prognostic, but not treatment guiding? Would you recommend adjuvant immunotherapy only if the patient has a ctDNA positive assay? Would you advise against adjuvant therapy if the patient's assay is ctDNA negative? Or would you use ctDNA to determine whether neoadjuvant therapy was necessary? So please log in your answers. Which of the following do you feel is appropriate based on the data? So let's talk about the data that might inform that decision. And then later we'll get to some prospective data that really, in addition to establishing clinical validity for ctDNA testing, which is really based on the data that I'm going to show you now, establishes clinical utility for ctDNA testing. So we have 3 studies that have asked a very similar question in patients with high-risk muscle-invasive urothelial cancer after radical resection. And that question is, should patients receive adjuvant therapy with immune checkpoint blockade, with PD-1 or PD-L1 blockade, or should they just proceed with observation? These studies were very similar in design, used very similar eligibility criteria, though there were some nuances and some slight differences in the primary endpoints of the studies. But there's a little bit of difference in how the studies read out. The study called IMvigor10, which randomized patients to a year of atezolizumab, the PD-L1 inhibitor, versus observation, did not meet its primary endpoint of disease-free survival. Ambassador, which studied a year of pembrolizumab versus observation, did meet its primary endpoint, showing an improvement in disease-free survival. And Checkmate 274 met its primary endpoint, showing an improvement to disease-free survival with adjuvant nivolumab. Of these studies, Checkmate 274 has led to regulatory approval for adjuvant nivolumab in patients with high-risk muscle-invasive urothelial cancer after radical surgery. So let's take a closer look at that data and really think about the value proposition of adjuvant immune checkpoint blockade in an unselected patient population. So here you see the disease-free survival curve for adjuvant nivolumab versus placebo in patients with high-risk muscle-invasive urothelial cancer after radical resection. And you can see some really important points here by just inspecting these curves. One thing that you see is that patients on the placebo arm, a fair amount of them do really quite well and are likely already cured with the surgery that they received, plus or minus neoadjuvant chemotherapy that they received. So arguably, these patients do not need further treatment. These patients, the space between these 2 lines, of course, indicates the patients who both need treatment and benefit from treatment. These are patients who got adjuvant immune checkpoint blockade, where it really seems to make the difference in terms of recurrence versus not. And then, of course, these patients received adjuvant immune checkpoint blockade, but still did not derive benefit from treatment, still developed disease recurrence. So if we think about these 3 scenarios, it really paints the perfect picture for implementation of a precision medicine-based approach, because clearly there are patients here that were overtreating, there are patients here that were undertreating, and there are patients here for whom this is really the appropriate treatment. So how do we determine this better? Well, if we can identify who needs treatment in the adjuvant setting, that would be a start. And sometimes it's conflated biomarkers of patients who need treatment versus biomarkers of patients who benefit from treatment. In the adjuvant setting, though, there's a double biomarker dilemma. Not only don't we know who benefits from specific drugs, but we actually don't even know who needs additional treatment because we don't know who has residual micrometastatic disease. And this is where ctDNA comes in. ctDNA is really the most promising biomarker that we've seen that might indicate who, quote unquote, needs additional treatment. So here's the retrospective data from the IMvigor10 study that I was referring to. You'll remember that this was a study of adjuvant atezolizumab for a year versus observation. The study didn't meet its primary endpoint, but the investigators from the study did a really important analysis. And what they did is ask retrospectively, would the results of this study have been different if we could determine ctDNA status immediately after surgery and determine whether or not that separated individuals into those who needed treatment versus those who maybe didn't need treatment. And you can see here in the first Kaplan-Meier curve, disease-free survival, the second overall survival, the curves are stratified according to ctDNA status, with patients with ctDNA undetectable assays on top, ctDNA positive assays on bottom, and then each curve indicates patients who were on the atezolizumab in blue versus the observation arm in red. And you can see immediately that patients with undetectable ctDNA did not seem to derive benefit from the adjuvant immunotherapy and had a much lower risk for recurrence. Patients with detectable ctDNA at that single time point after surgery had a much higher risk of recurrence and are the ones who seemed to benefit from adjuvant immune checkpoint blockade. So really important retrospective data establishing clinical validity for ctDNA testing in this setting. So let's go to this polling question. Your patient asked whether their postoperative ctDNA result could be used to predict whether adjuvant immunotherapy will improve their long-term outcomes. Recalling the IMvigor10 ctDNA analysis findings that we just reviewed, how should you interpret the role of ctDNA-based minimal residual disease testing as a potential intermediate clinical endpoint? A, it is promising as a biomarker, but its role as an intermediate clinical endpoint remains unproven. B, it's a validated surrogate endpoint that can replace disease-free survival and overall survival in adjuvant trials. C, it should be used to determine which patients can safely avoid adjuvant therapy. D, it confirms that only patients with detectable ctDNA benefit from adjuvant immunotherapy. Or E, it demonstrates that ctDNA can guide both neoadjuvant and adjuvant treatment selection. So let's dive into this data. And really what this polling question is getting at is whether or not we can use serial ctDNA values as an intermediate endpoint in the adjuvant setting. You'll acknowledge that historically, when we've done adjuvant studies, the only way to prove a benefit from a treatment, and in fact, the only way to test a treatment, was to do large randomized clinical trials with time to event endpoints, because there was nothing to measure in real time as to whether or not you were having a treatment effect. And so it really precluded smaller studies screening the activity of novel therapies in this setting. But with something measurable like ctDNA, this really opens up possibilities for smaller trials testing whether or not novel therapies have activity in this setting by analyzing whether or not detectable ctDNA can be cleared with such treatment. So what I'm showing you here is results from the IMvigor10 retrospective analysis, now looking at patients who had detectable ctDNA right after surgery and determining whether on treatment that ctDNA became undetectable or it stayed detectable. And you can see both disease-free survival and overall survival curves. If ctDNA converts from detectable to undetectable, patients have much better outcomes. So not a validated surrogate yet. This is one retrospective analysis, but it really suggests that this tool has the potential to be powerful in terms of clinical drug development. This tool, in terms of driving treatment decisions, in terms of serial values, conversion from detectable to undetectable, we don't know for sure how we could use that clinically yet, because, of course, if a patient starts on adjuvant immune checkpoint blockade or another adjuvant therapy and has a clearance of their ctDNA, that might be viewed as promising, but we don't yet know if there's not clearance of ctDNA that patient should be switched to a different treatment. Of course, we need more data to know that. The other data set that we have now from this series of randomized studies testing adjuvant immune checkpoint blockade is the retrospective data now from Checkmate 274. And this represents a much smaller set of samples because of sample availability by the time that the assay was performed. But same assay as I showed you in IMvigor10, the Signatera assay, applied to the Checkmate 274 study, which tested adjuvant nivolumab versus placebo. And here you see the disease-free survival and overall survival curves look really quite similar to the IMvigor10 analysis. Patients with undetectable ctDNA, not much separation in those curves in patients who received adjuvant nivolumab versus placebo. Patients with detectable ctDNA, that's where you see this large separation of the DFS and OS curves, suggesting that there is enrichment for benefit of adjuvant immune checkpoint blockade in patients with detectable ctDNA post-surgery. So I'm going to hand it over to Dr. Sfakianos to present the next section on ctDNA in urothelial cancer.
Hello, everyone, and thank you for taking the time to listen to this talk on coordinating ctDNA testing across the care continuum. My name is John Sfakianos. I'm a professor at the Icahn School of Medicine at Mount Sinai in New York, and I am actually a urologic oncologist. So these are my disclosures. The only relevant would be that I do participate in the Speakers Bureau with Natera, and I will be speaking a lot about their assay, the Signatera, in this talk, as that's where the majority of the bladder cancer data lies. The learning objective is to apply practical evidence-based models for cross-specialty coordination among urologists, oncologists, radiation oncologists, and advanced practice providers to ensure timely initiation of tumor-informed MRD testing, appropriate sample handling, and integration of serial ctDNA monitoring into perioperative care pathways. So basically is incorporating the entire team into the testing of MRD, tumor-informed MRD, and how we can coordinate it all in a timely fashion to help our patients make good decisions. I think in the past, we've thought about the idea of precision medicine or personalized medicine. And that was really the idea of us sequencing a patient's tumor, identifying a targetable mutation, and then acting upon it. While that has panned out for certain mutations like FGFR3, maybe HER2, in bladder cancer, it's not exactly been as dominant of a therapy as we would like. But I think that ctDNA now is really the true promise of precision medicine. And that is because not necessarily predictive on what therapy we can use, but definitely prognostic. And it will allow us to make treatment decisions based on that prognosis. So we can identify patients that may be best suited for adjuvant therapy. We can look at the risk of recurrences of patients. So a detectable patient, we may want to do surveillance a lot sooner and quicker than an undetectable patient. We can monitor responses to therapies and maybe make decisions about switching them in a more timely fashion rather than waiting for radiographic proven progression of disease. And we can monitor response to systemic therapies. And this is where the predictive part of it may come in the future if we can get more data in a timely fashion. Integrating the urologist, I think, is the most important part. Not that I'm biased because I am a urologist, but I think it allows for timely fashion of us ordering the MRD and then using that to make treatment decisions from the beginning. And what do I mean by that? I mean that as a bladder cancer surgeon, there's one thing, which is a transurethral resection of a bladder tumor, that many will argue is 100% diagnostic, but also therapeutic. I think maximizing the TRBT is absolutely important in muscle-invasive bladder cancer. And by doing so, you will be able to remove this tumor and have a large portion of tissue available in the majority of cases to send for tumor-informed testing. And so this is how we perform it here at Mount Sinai, and this is a schematic from a review that one of my fellows and I wrote a couple of years ago, or I'm sorry, about a year ago. And this is important because when we get this tissue sample, we can then send this out for whole genome, whole exome sequencing. And Signatera specifically has a 16 tumor unique mutation profile that is clonal. So this single tumor sequencing is enough for the patient's or the tumor's treatment lifespan, where you don't need another tissue sample. So you don't have to sequence metastatic site, you don't have to do other biopsies, etc. And so by sending this out early, you can actually start the process quickly, and then that process can longitudinally be followed without any issues. So anytime you get a blood serum, you have the sequence available, you have your 16 unique mutations, and then you'll be able to get the answers. And so the way I would do this is that I would do the TRBT. The patient about 7 to 10 days later will come to my office to discuss the pathology. And if there is an invasive tumor at that pathology, I initiate the process by sending out the Signatera assay. And so this is a question. Your patient with muscle-invasive bladder cancer has a tumor-informed ctDNA assay available. Before starting neoadjuvant chemotherapy, the ctDNA result returns positive. What would you do next to optimize their outcomes? All right. So why is this important? Well, there is now more and more data coming out of using MRD testing in muscle-invasive bladder cancer and in the different stages of the disease and how it can help us make decisions. But the initial data comes back from 2019, and this is the paper in JCO from Christensen et al. From the group at Aarhus Institute in Denmark. And what they did is they prospectively followed 68 patients with locally advanced muscle-invasive bladder cancer and performed longitudinal Signatera assay, where they had a total of 656 plasma samples. And you can see here on the diagram, these samples were taken at various time points throughout the patient's treatment or the tumor's treatment, that including a diagnosis, like I said, from the TURBT specimen, during neoadjuvant chemotherapy, before cystectomy, after cystectomy, and during the surveillance window. So on average, it was about 9 to 10 samples per patient that were available for analysis. And some of the key findings here was that ctDNA was extremely prognostic after TURBT and before neoadjuvant chemo. So those single time points were very prognostic. But more importantly, the longitudinal samples were the ones that were the most important. And so if longitudinally the ctDNA was not cleared, that was a better predictor of recurrence than pathological response and stage at the time of cystectomy. The lead time, so the time from where a test turns positive to radiographic imaging, confirming metastases, is 96 days. And then, like I said before, longitudinally, if is the most important, and if the ctDNA remains undetectable, that is a 100% overall survival. And you can see the Kaplan-Meier curves here for the single time points. Again, very prognostic, where a single time point before neoadjuvant chemotherapy showed a 3% risk of recurrence versus a positive, which showed a 46% recurrence. And the single time point after neoadjuvant chemotherapy, if still undetectable, 11 versus 75%. Very nice separation in the curves, showing that undetectable patients do well and detectable patients, unfortunately, do somewhat poorly. And more importantly is the longitudinal testing. Rarely do we ever see a Kaplan-Meier curve like this. And what I mean by that is you have a 0 to 100, meaning that if you stayed and remained undetectable, you had a 0% risk of recurrence. If you remained positive, you had a 100% risk of recurrence. And so these are extremely important prognostic indicators, especially in the longitudinal fashion. So single time point, important for counseling your patients. Longitudinally, extremely important to allow us to make better decisions for our patients. And that was in the neoadjuvant chemotherapy space, and those patients did really well. And as a urologist, I mean, I think it was extremely important from my standpoint as well. Well, if the patients do so well, can we similarly say that maybe this is the biomarker that we've been looking for to help us make decisions on which patients should get neoadjuvant chemotherapy? Meaning that if you're undetectable, do you need the chemotherapy? And the group from Aarhus had a similar thought process. And what they did is maybe an apples to oranges comparison, where they looked at their neoadjuvant chemo treated cohort from that prospective study that I just explained to you. And they compared that to a group of retrospective blood samples that they had for patients who were treated with cystectomy alone. So that was 68 patients versus 102 patients. Here we can see the curves on the left, here being those that were treated with neoadjuvant chemotherapy, and here on the right are the curves for the cystectomy alone. Now, it's not fair to compare these two because it's, obviously biased in many different ways. But what you can see is that there is still the same separation in the curves if you had cystectomy alone compared to those who got neoadjuvant chemo. So the patients who are undetectable do really well if they have if they go with surgery alone versus chemo and surgery. And so maybe this is the biomarker that we're looking for, and obviously will need to be tested more. So another question for the audience: your patient receiving neoadjuvant chemotherapy shows persistent ctDNA positivity on serial testing. Even though imaging remains stable, which action would you implement next to help optimize their outcomes? And so to further try to answer these questions, the group did do a comparison of their neoadjuvant chemo to their cystectomy only cohorts. And you can see the Kaplan-Meier curves here, where the green is the neoadjuvant chemo, the red is the cystectomy alone. In the undetectable cohort, you can see pretty much complete overlap in these curves. In the neoadjuvant I'm sorry, in the detectable, you can see pretty much overlapping of the curves. In the undetectable, you can see maybe a separation, but again, a pretty close um, lines, meaning and saying that maybe this is the biomarker that we need, but we obviously need to do a lot more studies, including a prospective study, to try to figure out the true answer of how we can use this this biomarker in maybe a predictive way to tell us which therapies the patients will most benefit from. Similarly, our group, given the excitement of this data, decided that we were going to send a ctDNA on every patient that was going for cystectomy. So this is a little bit of a less biased cohort, but still very biased, meaning that it's not in a prospective, it was collected in a prospective manner, but it was analyzed retrospective, but this is all comers. So we didn't necessarily bias ourselves. Very interestingly, what we saw is that the detectable patients, 88% of those patients were muscle invasive or higher, and that 44% were node positive at the time of cystectomy. And then we have shown that a detectable ctDNA prior to cystectomy is actually predictive of upstaging as well as node positivity. As you can see here, 66% of the patients with detectable ctDNA were upstaged. So those patients, regardless if they had neoadjuvant chemo or not, if they are detectable before going to surgery, they're likely going to have a bad pathological finding and will likely require more therapy. So this is one of the ways that we would use this test to help us make better decisions and actually counsel patients regarding how and what the next steps may be. And so this for me is very important in my practice. When I sit down with patients, I can absolutely use this to help counsel what their next steps are going to look like. And that's really important. And so this then leads me into the adjuvant discussion. And obviously the adjuvant discussion is the IMvigor011 randomized study that was just presented and published. And what this was similar to what I was just saying, that if the patients are detectable going into surgery, they usually have worse prognostic factors. Well, if they remain positive after surgery, we know that that's an extremely negative prognostic indicator. And we saw that from the work from the Aarhus and that Trombola trial that I presented. And so this was a randomized adjuvant therapy study. So this is an extension of IMvigor010, which an ad hoc analysis showed that even though it was a negative study, a positive or detectable ctDNA was actually a biomarker for patients that would benefit from adjuvant immunotherapy. And so IMvigor011 was designed, which was an adjuvant study for high-risk muscle-invasive bladder cancer patients who were randomized 2-to-1 to atezolizumab versus placebo. And most important was that the patients could have been detectable immediately after, so remain detectable, or they could have converted to detectable 21 months up to 21 months after cystectomy. So this is kind of 2-in-1, meaning that if you're still detectable versus can we salvage you if you are undetectable and then convert to detectable. Well, overall, this was a positive study. Overall, this was a positive study. And I think that adjuvant therapy is extremely important for these patients. And when we look at how we can use this, we can similarly show a patient representation of a patient's Signatera assay curve, because this is what you would get. You would, as results, you would see on the y-axis the actual quantitative amount of positive ctDNA, and this is mean tumor molecules per ml in the plasma. And then on the x-axis, you have the time. And you can see that you can have various actual results for these patients. So you can say at presentation, the patient was positive, surgery made him negative. During the MRD window, those first 3 months, he started to have a recurrence. He started getting treatment, started responding to that treatment, et cetera, et cetera. And so this is where the cross-specialty communication is extremely important, because as a urologist, I would be seeing this patient here before surgery and then maybe immediately after surgery. And so when we see these types of results, it's extremely important that we communicate with our medical oncology colleagues or even our radiation oncology colleagues, whatever it may be, to help get the patients to the next level of care in a timely fashion. So in conclusion, I think it's important to have discussions across specialties, urology, medical oncology, radiation oncology. I think the urologist should really be sending out the Signatera assay or any MRD assay, especially in that first week after the TURBT, to allow us to start the process. And by the time we need to make definitive medical decisions, that we actually have that result to help us make those decisions. I think in developing institutional policies for ordering and analyzing the data is extremely important. And so for a process like in our institution, it's pretty much automatic. A patient comes into the office and has a invasive bladder cancer diagnosis. I rarely have to think twice because everybody around my staff knows to just go ahead and proceed by ordering Signatera. It should be initiated by the urologist, like I mentioned before, and I think longitudinal sampling is essential. While the single time points may allow us to have prognostic discussions, I think the longitudinal sampling is extremely essential to allow us to make better treatment decisions in a quick fashion, as well as the open communication within our colleagues to let them know what is happening is essential for that longitudinal sampling. I thank you for taking the time to listen.
So now let's talk about how we might apply ctDNA results to guide individualized care. And of course, we've spoken a lot about retrospective data, which establishes clinical validity. But to inform practice, we really want data prospectively establishing clinical utility. So we're going to talk about interpreting ctDNA results to inform patient-centered decisions, balancing escalation and de-escalation of approaches in the adjuvant setting and in potentially the neoadjuvant setting moving forward as well. So let's start with a polling question. Your patient who had a ctDNA negative assay immediately after cystectomy has a new detectable ctDNA result at surveillance follow-up. There's no evidence of disease on imaging. To optimize their care based on current evidence, how should you interpret this finding? A, consider conversion clinically insignificant unless imaging shows recurrence. B, repeat the test in a year because ctDNA is not clinically meaningful. C, consider the results indeterminate, continue surveillance without changing treatment. D, recognize this as molecular recurrence that may warrant treatment escalation. Or E, recommend immediate repeat cystectomy. So go ahead and log in your answers. So let's talk about the prospective data that is now informing some of these treatment considerations. IMvigor11 is a study that really mimicked IMvigor10, which we already discussed, but it was done in a prospective fashion, seeking to validate the retrospective ctDNA findings from IMvigor10. The study enrolled a very similar patient population, patients with high-risk muscle-invasive urothelial cancer after cystectomy, and high risk was defined by the pathological criteria outlined on this slide. But after surgery on this study, patients underwent ctDNA testing using the Signatera assay. And if they had detectable ctDNA immediately after surgery, then they were randomized to receive atezolizumab, the PD-L1 inhibitor, or placebo, and atezolizumab was given for a year. In patients with undetectable ctDNA, they had serial ctDNA monitoring every 6 weeks initially. And if they had conversion of their assay from undetectable to detectable, then they entered the randomization later. And that could be any time during the first year of follow-up. So there's really two groups of patients to consider. There's the patients who had a detectable ctDNA assay immediately after surgery. And then there are the patients who had conversion from undetectable to detectable anytime during that first year of follow-up. The study was designed really to look at patients with detectable ctDNA treated with atezolizumab versus placebo, regardless of the timing of that ctDNA detectable assay. And so the data are presented in the manuscript and when the study was initially presented in that fashion. But of course, there is some subgroup analysis of patients who had detectable ctDNA immediately after surgery versus later that are relevant to our clinical decision making as well. And so some of these numbers here are reconstructed as best as possible from the paper to try and contextualize this data into how we think about informing treatment decisions and how we advise patients. So 607 patients were included in the analysis. 459 of those patients had a baseline undetectable ctDNA test. And those patients, remember, were monitored with serial ctDNA testing. Of those patients, 102 had conversion of their ctDNA assay from undetectable to detectable during that year of follow-up, first year of follow-up. So a conversion rate of about 22% during that first year. 148 patients had a baseline detectable ctDNA test. Here are the results of the impact of atezolizumab versus placebo on disease-free survival and overall survival. In the top panels, those are patients with detectable ctDNA immediately after surgery. And in the bottom panels, those are patients who had undetectable ctDNA initially, which converted to detectable during follow-up. And what you see in all of the curves is that there's a significant benefit to atezolizumab versus placebo in patients with detectable ctDNA if that ctDNA was detectable at baseline after surgery or if it was detected during follow-up in a conversion from an undetectable to detectable assay. These lower panels here, this is really a new clinical disease state. This is molecular recurrence of bladder cancer. And it's really the first demonstration that intervening on molecular recurrence is clinically relevant. That is, one can improve outcomes by treating individuals with an intervention who have a conversion from an undetectable to a detectable ctDNA test. And of course, the panels on top reinforce that patients with detectable ctDNA after surgery certainly need to be considered for adjuvant therapy. The study also evaluated the potential impact of undetectable ctDNA on treatment decisions, but here the data are a little bit more nuanced. So what I'm showing you here are the outcomes of patients who had undetectable ctDNA serially during that year of follow-up, both disease-free survival and overall survival. And what you see here is that if an individual has a persistently undetectable ctDNA test, then their outcomes are really quite good with a small risk of developing recurrence. However, patients who had a conversion of undetectable to detectable ctDNA during that first year of follow-up before developing metastatic disease on a scan are not represented on this curve. These patients entered the randomization, and so they're removed from this curve. So remember, this only represents patients who are serially negative. And when you're informing a treatment decision immediately after cystectomy in a patient with a baseline ctDNA undetectable assay after surgery, of course, you don't know that they will be serially negative during a year of follow-up. And so what we don't know for sure is that the watch and wait approach is non-inferior to the treatment of all approach immediately after cystectomy. But of course, if we treat everyone with an undetectable ctDNA after surgery, we will be over-treating people. And we saw that treatment upon molecular conversion improves outcomes. And so that really reinforces that this is a concept that we should collect additional information on to confirm that we can watch and wait in the setting of an undetectable ctDNA test. So really the take home here are the messages that I just outlined. Patients with detectable ctDNA after surgery really should have adjuvant therapy. Molecular recurrence is a new clinical disease state that's clinically actionable. And patients with serial ctDNA negative assays have an excellent prognosis. Of course, if we knew patients would have undetectable ctDNA serially at the time that adjuvant treatment decisions need to be made, then of course that would allow us to de-escalate treatment in a much more rational way. So these concepts are really being explored further in the ongoing modern study, which is randomizing patients, similar patient population, patients with high risk muscle-invasive urothelial cancer after radical surgery. Patients after surgery have ctDNA testing using the Signatera assay. Patients with detectable ctDNA assays are randomized to adjuvant nivolumab, PD-1 blockade, standard of care, versus a doublet of nivolumab plus relatlimab, seeking whether or not we can escalate treatment to try and improve outcomes even further in patients with detectable ctDNA after surgery. In patients with undetectable ctDNA, we're really trying to address that question that I just reviewed, which is it as good to just monitor patients and treat only the subset of patients who develop molecular recurrence, which is quite a compelling approach in terms of trying to not overtreat patients? Is that approach non-inferior to treating all patients with adjuvant nivolumab? And so the study is enrolling, and hopefully we'll address some of these key remaining questions. So let's return to a polling question. Your patient with muscle-invasive bladder cancer received neoadjuvant cisplatin-based chemotherapy plus immunotherapy. Their ctDNA test is positive at baseline, but becomes undetectable prior to cystectomy. Based on current evidence, how should ctDNA clearance influence your postoperative management? A, it indicates that they no longer need adjuvant treatment. B, it confirms that they achieved a pathological complete response. C, it suggests a favorable response but does not replace postoperative treatment. D, it means that their recurrence risk is equivalent to someone with ctDNA negative assays at baseline. And E, it allows ctDNA testing to replace pathological assessment at surgery. Please go ahead and log in your answers. So we have one large data set and several smaller data sets evaluating the potential role of ctDNA testing in the neoadjuvant setting. And that data set comes from the Niagara study. And this was a randomized study of gemcitabine cisplatin plus or minus durvalumab in patients with muscle-invasive bladder cancer. And patients who were randomized to the durvalumab arm continued durvalumab after surgery, after cystectomy in the adjuvant setting. This study demonstrated an improvement in event-free survival and overall survival, leading to regulatory approval of this treatment regimen for muscle-invasive bladder cancer. And again, ctDNA testing was evaluated in a retrospective fashion in the study using the same assay that we've been discussing, the Signatera tumor-informed ctDNA assay. And here you see the detection rate, detectable versus undetectable ctDNA in this total study population, and then according to treatment arms in 3 different phases of the study: at baseline, prior to neoadjuvant treatment, after neoadjuvant treatment and before cystectomy, and then after cystectomy. And if you look at the BEP, the biomarker evaluable population, the total population here, you can see a few messages that are clearly apparent. One is that many patients, but not all, have detectable ctDNA at baseline. 2, that ctDNA clears in the vast majority of patients on neoadjuvant treatment, but not all. And 3, after cystectomy, that rate of ctDNA detectability goes down even more. So what does that mean from a prognostic standpoint? So here you see the impact of baseline ctDNA on outcomes in this study, detectable versus undetectable. And clearly, patients with undetectable ctDNA at baseline have a better prognosis than patients with detectable ctDNA. But you'll see that patients with undetectable ctDNA in this large study where everyone got perioperative systemic therapy, there's still a decent risk of having an EFS event with an undetectable baseline ctDNA test, arguing that perhaps baseline ctDNA is not ready for prime time using this approach to determine which patients should and should not receive neoadjuvant therapy. Now, arguably, this did not include an arm where patients had cystectomy alone, so this does not prove that patients with undetectable ctDNA at baseline benefit from neoadjuvant treatment, but it does tell you that in a study where all patients got neoadjuvant treatment, the outcomes are still, the risk for recurrence is not insignificant in patients with an undetectable ctDNA assay. So let's circle back to the main messages about ctDNA in muscle-invasive urothelial cancer based on the rapidly evolving data. ctDNA tells us who needs adjuvant treatment. We know that from 2 large retrospective analyses, and we know that from 1 prospective study establishing clinical utility for this approach. ctDNA tells us who doesn't need adjuvant treatment. Maybe the results from IMvigor11 are compelling, but we need to make sure that the watch and wait approach is non-inferior to the conventional adjuvant approach, and we don't have randomized data assessing that comparison yet. ctDNA does not yet tell us who doesn't need neoadjuvant treatment. However, the data is evolving here, and with additional studies and improved assays, there is the likelihood that we will get there. Thanks so much for your attention. Before we move to questions, I'm going to bring on to the screen our QR code for today's session. You'll need to scan this whenever you're leaving to claim the CME certificate, which is completely free. I'll also place the link in the chat box and we'll show it again at the end. Now we have time for some questions. Okay, well, thanks everyone for joining. We're going to go through some questions and answers here. And to start, in the adjuvant immunotherapy trials where ctDNA was analyzed retrospectively, what specific methodological limitations prevent us from using those data as treatment guiding evidence? Maybe Dr. Sfakianos, I'll take this one, and then we'll move on to the next one. So a couple of limitations. One of the limitations, of course, is that in retrospective studies, those are limited by specimen availability, and oftentimes the specimens are banked for a while before they're analyzed. And so that does create some potential for bias in terms of the patient population who ultimately has data in these phase 3 trials versus a prospective study where you're ideally collecting the information on all of the patients as they're entering the study. Let's move on to the next one. So how should we distinguish between ctDNA as a prognostic biomarker identifying recurrence risk and a predictive biomarker identifying benefit from immunotherapy when interpreting IMvigor10 and Checkmate 274, Dr. Sfakianos?
Thanks, Matt. So this is, really challenging question because we always are trying to differentiate between a prognostic and a predictive biomarker. And while I do think that, we not only from IMvigor 010, but also from IMvigor 011 and the data from Checkmate 274 and so forth and so on, we know that that ctDNA is a prognostic marker. So we do know that the patients who are undetectable usually do worse than the patients who are detectable. But for it to be a predictive marker, I think as I think Matt had mentioned in some of his talks, we need to do studies that can really answer that to that specific, will this therapy help or not help? And I don't think that, those those studies have been performed or completed yet to really assess if ctDNA is a predictive biomarker, but I think we can say that it is prognostic.
And I think it's particularly challenging in the adjuvant setting when there are studies randomizing against observation or placebo because the two concepts are obviously intertwined. You can't benefit from treatment if you don't need treatment. And so it might look like it's predictive, but it might not necessarily be predictive for the specific treatment that's being tested. It just might mean that patients can't benefit from treatment if they don't need it. So your ability to show a benefit of treatment is enriched in patients with that biomarker, right? Okay, we'll take the next one. So given that IMvigor11 prospectively randomized ctDNA positive patients, does this fully establish ctDNA as treatment guiding, or are there still unanswered questions regarding de-escalation in ctDNA negative patients? So maybe I'll give my 2 cents and then Dr. Sfakianos will weigh in as well. So IMvigor11 really tested a ctDNA positive question. And of course, there were patients who had undetectable baseline tests and they were followed serially as both I reviewed and Dr. Sfakianos reviewed. But the randomization was a randomization in patients who were detectable. And so that creates a little bit of challenge in terms of the negative question in this study because there's no randomization in patients who were undetectable immediately after surgery to treatment versus monitoring. So what does the trial tell us about patients who had undetectable ctDNA at a single time point after surgery? Well, one, it tells us that the risk of molecular recurrence is about 22 to 25%. The risk of developing metastatic disease before ctDNA turns positive was more about 5%. It also tells us that if you treat upon molecular recurrence, you can improve outcomes, disease-free survival and overall survival. But improving overall survival is not synonymous with curing cancer. And that's the whole point of giving perioperative systemic therapy is to try and cure cancer. And so what we don't know for sure is waiting until molecular recurrence and treatment if that's non-inferior to giving treatment right after surgery. The data looks promising, but to really answer that question, you would need to randomize patients with undetectable ctDNA after surgery to a watch and wait approach versus a treat immediately approach. And that's actually the randomization, one of the randomizations in the modern study that's ongoing now. Dr. Sfakianos.
Yeah, I mean, I think that was really well said. I mean, I think for the purposes of de-escalation, we have not seen a properly powered study for that, to answer that exact question, but it is the arm in modern that will give us a lot more information in terms of the watchful waiting or the surveillance part of it. As one of the things we do know that yes, some patients will convert from undetectable to detectable, but the majority of the patients actually do not. They remain undetectable. So it's not really a watchful waiting, but more of a surveillance or, those patients we can consider being cured, like Dr. Galsky had just mentioned. And so there's a lot more to be learned and a lot more studies that will be necessary for us to answer these questions, especially the de-escalation question. But it is an exciting time because some of those studies are ongoing, like modern, and we're going to get a lot of really great answers in the future to help us and guide us on how to use ctDNA.
Thank you. Let's go on to the next one. Are there false positives in ctDNA? So I think this is a great question. Yes, there are. And very interesting analysis presented at ASCO GU from IMvigor11. So in IMvigor11, they looked at the patients who had detectable ctDNA after surgery in the control arm of the randomization. So these patients were randomized to placebo. And there was ctDNA clearance in that group of patients I forgot the percentage of patients. It was about 10 to 15% of patients. So not on any active treatment, detectable ctDNA after surgery, and clearance in a subset of those patients. And that clearance was associated with better outcomes, better long-term outcomes. So there are a few potential, and one additional nuance to that, the quantitative values of ctDNA in those patients was much lower than in patients with detectable ctDNA who didn't have clearance in patients on the treatment arm. And so what that tells us is, one, those could be false positives, or two, potentially there's some immune editing going on where those were actually true positives, and the immune system cleared that ctDNA spontaneously. So some interesting data relevant to this question, but actually there are other potentials for false positives as well. Dr. Sfakianos, you want to comment?
Yeah, no, I agree with both of those. I actually think that, we need to understand that the clearance, the immune clearance of fragmented DNA goes back. It's a very conserved mechanism that goes back almost to single cell biology. From the standpoint that our liver, the complement immune system, specific macrophages. So this is something that's been conserved and developed over time to clear fragments of DNA. And that's not necessarily because of tumor DNA, but it's actually normal DNA from injured cells, from infections, you know, um, et cetera. So, this conserved method, I'm sorry, is probably what plays a role in these very low levels of DNA that are picked up that then are cleared because the immune system identifies it, and it just needs that timing to be able to fully clear it. So I think there's a lot of really exciting biology that we have not quite uncovered yet in these patients who have these low levels of positive ctDNA. So, but I do think that that's an important part of it.
Thank you. Let's move on to the next one. So, can ctDNA clearance during adjuvant therapy be considered a validated surrogate endpoint for long-term outcomes, or is it still hypothesis generating based on current evidence? So I think that we certainly want to qualify the term surrogate endpoint. So I think it's an intermediate endpoint, and it's an intermediate endpoint now based on several analyses where clearance of ctDNA correlates with better time to event outcomes, including in the IMvigor10 study and the IMvigor11 study. So that if you're on treatment, your ctDNA converts from detectable to undetectable, that's associated with a better long-term outcome. This is actually ctDNA clearance is the phase 2 endpoint of the seamless phase 2/3 design on the modern study on the arm that randomizes patients with detectable ctDNA. So we do think it is a measure of the activity, the anti-tumor activity of novel therapies. Whether or not it's a validated surrogate that that captures all of the information that is related to long-term outcomes like survival, that's probably a different story. But certainly seems to be a good intermediate endpoint for screening the activity of new therapies in this space, where traditionally we had nothing. We would have to do large randomized studies and wait till time to event endpoints because there's, by definition, really nothing to measure historically in the adjuvant setting. Let's move to the next one, which we'll ask Dr. Sfakianos to comment on. So is there a point where you may recommend ctDNA monitoring to allow for a reduction in imaging-based monitoring? Great question.
Yeah, I think that's a really great question. And I have to give my honest answer, which is yes. I actually personally, our group looked at this and we looked at the status of ctDNA within 30 days of surveillance imaging for patients. So these are patients that are outside the MRD window and they're during the surveillance. And we saw that there was a complete concordance. So if you're undetectable, 100% of the scans were negative. If you converted to positive at any point, then there was 100% with a lead time bias of about 90 days or so of the imaging turning positive. And so I do think that this is slightly a little bit more dangerous at this point, that we do need the proper study to prospectively validate these findings. But I do think that from the data that we have so far and what we've looked at, I do think that if you are an undetectable patient that has passed maybe the 2-year surveillance mark or is around there, that I will sort of lean a little bit more on the ctDNA than getting imaging per guidelines. So if you're a T4 patient, maybe, twice a year rather than 3 or 4 times a year. But if you're a T1 patient that's detectable, I would probably and I do increase my surveillance imaging every 3 months rather than every 6 months based on guidelines. So I think it goes both ways.
Thank you. Let's move on to the next one. From a practical standpoint, where should you own the initiation of tumor-informed ctDNA testing after TURBT, or who should own the initiation? After TURBT or cystectomy, the urologist, the medical oncologist, should this be reflexively embedded into pathology workflows? So I think there is certainly some benefit based on the timelines of completing current tumor-informed testing. It is quite helpful to have that initial test performed prior to surgery so that the testing after surgery comes back quickly enough to be able to be integrated into a treatment discussion with a patient. So I think, the urologists are the ones who diagnose bladder cancer. They're the ones who do TURBTs. And testing in that space, I think, is becoming more and more common, as Dr. Sfakianos outlined in his talk. Next slide, or sorry, next question. So this will be the last one. So if a patient clears ctDNA after neoadjuvant therapy but still has residual disease at cystectomy, how should we integrate ctDNA kinetics with pathological staging when deciding on adjuvant therapy? Dr. Sfakianos.
Well, this one's a loaded question. I do think that this is basically IMvigor011 that Dr. Galsky, nicely highlighted in his discussion and I mentioned. And so I do think that based on that, if there is still detectable, those are the patients that should, pretty much immediately get adjuvant therapy. I do think that the undetectable patients, it's still a conversation to be had, with the treating physician and the patient and, have an understanding between the two, because I do think that some of the undetectable patients, should probably get adjuvant therapy if there are some pathological features, because there is that conversion risk and there are some of the undetectables that do become metastatic without converting to detectable. And so I would say that those who are still detectable should definitely get adjuvant. I think the undetectable should have some shared decision making with the treating physicians. And the important part of IMvigor, which I think it wasn't powered, but again, modern will help us with this, was that really you can convert it to detectable any point within 21 months after the surgery. So there is that possibility of salvage. It wasn't powered to that, but at least if you look at the sub-analysis, you did see some separation in the curves. And so all that has to be sort of dictated and discussed with the patient to have a shared decision making.
Okay, thank you for your questions. I want to say thank you for joining us today. Importantly, I'm going to bring up on the screen our QR code once again for today's session. Remember, you'll need to scan this to claim your CME certificate, which is completely free. I'll also place the link in the chat bot. Before you leave, we'd like to encourage you to stay and listen to a brief interview with the patient advocate. Keeping the patient at the center of care is an important component of our education at MEDAL. And hearing directly from a patient advocate helps ground these concepts in real-world care and highlights the importance of communication and shared decision-making as treatment options evolve. I hope you found today's session helpful and interesting. It's been a real pleasure to host you. If you enjoyed this session, please be sure to check our other resources at medalleducation.com, where you can claim CME credit for participating in all of our free CME programs. Let's turn to Joy, who will share their experience. Thanks again for joining us.
Welcome. As we explored throughout this program, biomarker-guided approaches are increasingly influencing care decisions in muscle-invasive bladder cancer. But it's equally important to understand how these decisions, tests, and conversations are experienced by patients and caregivers. We're pleased to welcome Joy, who is joining us from Bladder Cancer Advocacy Network, or also known as BCAN. Joy brings the patient voice into this discussion and represents individuals and families navigating diagnosis, treatment, and follow-up care. Joy, thank you so much for being here with us and for sharing your perspective today.
No problem. Thank you for having me.
So to start, can you briefly share your connection to bladder cancer and your connection with the Bladder Cancer Advocacy Network?
Sure. I was diagnosed with muscle-invasive bladder cancer in June of 2024. At 54 years old, I had no risk factors. I was a non-smoker, never had any contact, occupational contact with dyes or anything like that. So in very good health otherwise. In early 2024, I visited my primary care physician because I thought I had a UTI, but I did not have an infection. And so after seeing some microscopic blood and some past results, she suggested I go to a urologist. So I made an appointment, and like any specialist, it takes a while to get in. And before that visit, I actually passed a blood clot. Then I waited. It was probably another 3 weeks before that urologist visit came up. And so I knew I might need to be concerned at that point. And when I got in, it was obvious that she was on go method. So she started doing the scope, the CT scan, the tumor removal all happened within a few weeks of that visit. She was able to confirm that the cancer was an invasive muscle, bladder cancer. And having no knowledge about bladder cancer, I did what everybody does, and I went to research on the internet. So I started researching medical sites and looking for a good book, by a doctor. And I thought, well, every cancer has a group. So I searched, and that's how I found the Bladder Cancer Advocacy Network, or Beacon. And their website was a great resource for me. I attended a few virtual female support groups, just basically not even participating, but able to listen in on that. And it was very helpful to see somebody who had gone through what I was getting ready to experience. So I also attended they have summits. So I went to the fall summit, and now I'm a survivor to survivor volunteer. So if someone is diagnosed, they can reach out to Beacon and be connected with the right person to help kind of walk them through the experience.
Thank you for sharing that background, Joy. It's going to be really helpful for our audience to understand the perspectives you're bringing today and the experiences you hear from patients and families. So when bladder cancer becomes muscle invasive, patients are often faced with complex and time-sensitive decisions, as you've mentioned as well. From a patient perspective, what felt most overwhelming and unclear at that stage?
By the time I was diagnosed, it was muscle invasive. So that actually eliminated some of the decision making for me. I've had other bladder cancer survivors say to me that, well, you didn't have the choice. So that was, obviously it was very, very serious, and that's true. But also, I think it's probably more stressful to have that decision with the decision making with the physician, as far as, can we preserve the bladder, or does it, when do we remove it? So I think that is, in my eyes, was probably more stressful for someone else. So by the time, that all happened for me, and my doctors agreed that, I would need a particular path, I think the most complex decision for me was personally what type of urinary diversion method I would choose. That was stressful for me. So other things, were things that I just had no choice on. But the decision that I was about to make was going to alter the rest of my life and how I would, function as far as the bladder goes. So, some surgeries were either easier than others. The recovery time was longer. So I was healthy otherwise. I chose to do the neo-bladder personally, which has worked out very well for me. I've been very fortunate, but that decision was stressful because I knew it was permanent and would change my lifestyle.
Thank you. And what you covered really highlights how much information and, as you mentioned, different methods patients are trying to process in a short period of time, often while also dealing with a fear and, uncertainty. And as you also highlight, the decisions that are going to stay with you for the rest of your life. How do patients typically feel when waiting for results or hearing about molecular or blood-based tests after surgery, especially when imaging may still look normal?
When my physician spoke to me about the blood work, I was excited that there was a circulating tumor DNA test, there was something like that tool that could be used. I didn't even know it existed. And my oncologist explained how he would monitor the blood work after surgery to try to catch anything as soon as possible. After my surgery, I had a positive margin that it was of concern. And so some of the pathology wasn't crystal clear. And so even though they were able to tell that the chemo worked, they still weren't quite sure if they had gotten everything. So within 2 months after my surgery, I had the blood work done. And of course, like any CT scan or any other test, you're anxious, of course. But the blood monitoring to me feels like something proactive that I'm doing. So we're trying to catch it before you can even see it on the scan and make sure it's clean. And then if it is clean, that's even more assuring because it's, again, I don't know. I just think like in a way, it's more reassuring to have that information than to not. So it feels very proactive. And when you're waiting, it feels like you're waiting for a grade that you're waiting to receive in college. Like, did I pass or is there more work to do?
And what you've just described really also underscores the emotional weight that testing, monitoring can carry. And as you also said, even when there are no visible signs of the disease just yet. When treatment or surveillance decisions are being discussed, what would you say helps patients feel included and confident that their values and preferences are being considered?
That's a great question. I have a team of doctors and nurse practitioners that I feel very blessed to have handling my care. They listen. I've had several questions and they've answered every one. I've never felt like there was any question that I couldn't ask or, and they've told me the risk involved and provided me realistic timelines. So I think that helped me to be very mentally prepared for all of it. I didn't have a real, I didn't feel like I had control over the decision on the bladder removal, but what I did have control of was who I chose to be my medical team. So I wanted doctors that would listen, that would answer my questions, and understand also that I would, need second opinions, just to feel confident in the overall plan. So I think it helps to build that trust and therefore reduce the stress. So if some patients want more information like myself, or maybe they don't want as much, but just feeling confident that the treatment decisions, there's a lot of communication between the parties involved. I think that's key.
Mhm. And it sounds like emphasis really is here on the communication and inclusion, and the importance shared decision making has on patient-centered care. Now, living with uncertainty is a recurring theme in cancer care. How do patients describe coping with uncertainty when test results suggest risk, but there are no physical symptoms yet?
Uncertainty is stressful. And the older we get, I think the more we learn that there's a lot we don't have control over, cancer being one of them, of course. So even if we try to prioritize our health, there's only so much that we can control. I think once you've had cancer, if you're lucky enough to get a clean report, in the back of your mind, you always know that there's that risk that it could, return. So coping can be just trying to reduce stress, and keeping our minds occupied on work or family. I was very thankful that I was still working during that, because it did kind of help me divert my thoughts, and keep a clear head and keep focused on something other. So if you can do that with work, family, volunteering, I think that's beneficial. But it's just taking one day at a time, and the whole process and timeline can be very overwhelming. So of course, having others to lean on for that emotional support is very helpful. And having, just like with Beacon, if you can have a connection to someone that's experienced it, that was extremely beneficial to me, like to know and hear others had gone through it and gotten to the other side.
This is a really powerful reminder for our audience that uncertainty doesn't end when treatment does, and ongoing support, reassurance, they remain critical. Thank you for that.
Yes.
Based on what you've seen or experienced, what is one thing clinicians could do differently or more consistently to improve the patient experience when using biomarkers to guide care?
I think it helps a great deal to set realistic expectations for your patients. So when I received my first biomarker results, I was excited. They were great results. And my oncologist quickly reminded me that, we're just getting started. These are great results, and it's great to celebrate the wins, but it's sometimes, temper your excitement and let's take it one step at a time. So I think that's helpful, because if you do get that result that isn't what you had hoped for, it doesn't mean the end of the road. It's just a detour. You just take a turn on your treatment, come up with a different plan, and it's very proactive and forward thinking. So the biomarker information is just helpful in mapping that out and steering things in the right direction as quickly as possible. And I think if it's explained, that it's a guide and a tool in treatment, that patients will realize the advantages of it. And it can be a very positive thing for them, very hopeful.
Thank you. Those are very practical insights, and I'm sure they will be helpful for clinicians who are working to integrate these tools thoroughly into care. If you could leave clinicians with one key message about caring for patients with muscle-invasive bladder cancer, particularly as care becomes more personalized and data-driven, what would that message be?
If I could leave with one key message, I think it would be to share all the resources that you can with your patients. The person walking through the door is probably in shock. They're scared, they're confused, they're running through all the what ifs in their mind. And for a few months, I just kept thinking someone was going to call me and tell me they had messed up. That was not my, I felt fine. So it didn't make sense in a lot of ways. So there's a lot of confusion. Explain things clearly, but communicate the timeline well, but use the resources to kind of help the patient go through that whole process. I think there's a lot out there. The Beacon website is great. Help them connect with people that have gone through the experience, because although you may have treated someone with that, walking through it, it's just very powerful to talk to somebody with the same situation. So I think providing resources that are valuable can help somebody who feels powerless a little less so.
That's a powerful message to end on. Thank you so much, Joy, for sharing these reflections and for bringing the patient voice into this program. Your perspective reinforces why clear communication, coordination across care teams, and attention to patient values are essentials as care continues to evolve. And to our audience, thank you for listening.